Hi there. I'm Michael Lerner. I'm a laryngologist at the Yale School of Medicine, and I'm speaking to you today from the Voice Center in Greenwich, Connecticut. And it's my pleasure to speak with you on the topic of vocal health. This talk is really meant for anyone who uses his or her voice, and we've titled it For Anyone Who Talks, Laughs, or Sings. This session or webinar is being pre-recorded, so if you have any questions or comments, I would love to hear from you. Please feel free to email me or contact our offices. We'll have my contact information at the side of the presentation, and I will also present it at the final slide. So I have no disclosures. So what is so special about the human voice? I mean, we all use our voices in different ways to achieve different things in our lives. It's really a wonderful way, if you think about it, for us to be able to express our innermost thoughts and to communicate with one another, of course. When you think about voice use, people use their voices in very different ways. We think about the arts, singing. Some use their voices on the professional level, but not all of these occupational voice users are professional singers. These are our teachers, our clergy, lawyers, and the list goes on. Many of us rely on our voices to communicate and to succeed at work. But we also use our voices for jobs that don't pay, that is being a parent. And of course, we use our voices in ways to express emotion and to express also sadness, but also joy. And it's a really important part of our quality of life. And finally, our voices really are a really important way for us to have our sense of identity and sense of self. So that sense of identity in our voice actually is very intertwined. So I feel fortunate to practice laryngology or voice medicine and surgery. It's really at the crossroads of the arts and medicine. So before I go on, I thought I should explain a little more about what a laryngologist is. So a laryngologist is a physician, surgeon specialist who treats disorders of voice swallowing and breathing problems. And laryngology is a branch of otolaryngology, or otherwise known as ear, nose, and throat, ENT. And what's different about a voice center or a swallow or dysphagia center is that I work as a laryngologist hand in hand with speech language pathologists to provide patients with an interdisciplinary model or team approach to their voice or swallowing disorders. So who cares about voice? I mean, obviously I do. I've dedicated my professional life and career to this, but I would argue that many people do, including the entire country, as evidenced by this 2018 Super Bowl commercial.
In Austin, it's 60 degrees with a Alexa?
Amazon's Alexa lost her voice this morning, causing a
Alexa lost her voice. How is that even possible?
We have the replacements ready. Just say the word.
You're sure this is going to work?
Yeah.
Alexa, show me a recipe for a grilled cheese sandwich.
Pathetic. You're 32 years of age and you don't know how to make a grilled cheese sandwich. Its name is the recipe, you...
Alexa, how far is Mars?
How far is Mars? Well, how am I supposed to know? I've never been there. This guy want to go to Mars. For what? There's not even oxygen there.
Alexa, set the...
So, I mean, that video, humor aside, really demonstrates how, for some people, their voices are really intertwined with their personas, especially for celebrities, but not only celebrities. If you think about your family members and the sound of their voices, or your teachers, etc. And if one were to lose his or her voice, certainly this can be very impactful. So just to outline what I plan to cover in today's webinar, first we should define or describe what the larynx is. It's otherwise known as the voice box. We'll talk about its anatomy and function. And of course, this will lead to our discussion surrounding the causes of hoarseness, or what's known in medical terms as dysphonia. And finally, we'll discuss some of the principles of vocal health, which hopefully we can apply to our daily lives. So what is the larynx, or the voice box? The larynx, or voice box, is located in the center of the neck, and it is a cartilaginous structure. So it's made of cartilage, ligaments, muscles, and then a mucosal lining, like the lining inside of our mouths, like in our cheeks. And it is a complex structure in a sense, but simply put, the larynx is a valve. It's a biologic valve that sits at the junction between the aerodigestive tract, so the breathing and swallowing tract. Essentially, the valve is allowing food to go one way and air to go the other way. So the larynx has three main functions. The most important and the most primitive from an evolutionary standpoint is protection against aspiration. That is, when we swallow and we're eating or drinking, it's to prevent food or drink from going down into our trachea and then our lungs. This valve also modulates our breathing. And then finally, the valve eventually evolved to allow for voicing, or phonation. So this slide just is depicting the different functions of the larynx. At the top left, you see the swallowing function here. The larynx valve closes to prevent this, in this case, barium contrast from going down into the lungs. And then this image is meant to depict respiration, as some might recognize from the Apple Watch breathing app. And of course, we have Taylor Swift, who's performing the phonatory task or voicing function, which is the focus of today's talk. So this is a view of the larynx outside and then inside of the neck. And here we see the distinct cartilages that make up this structure. This is what would otherwise or colloquially be called the Adam's apple, or the thyroid cartilage, which we recognize when we look at people's necks. And then that sits atop the trachea here. And here, this is the cricoid cartilage, which sits right below the Adam's apple. So we won't go into incredible detail, but let it be enough to say that these cartilages on the outside protect the delicate structures on the inside, which are the vocal cords here, which really represent the main portion of this valve, which sits on top of the trachea or windpipe. Now, there are many muscles and cartilages on the inside that control the function of this valve. The main functions are opening and closing, but it is more nuanced than that, of course, because we simply aren't just breathing and coughing. We're able to use our voices in all sorts of ways, raising the pitch by stretching the vocal cords and taking all different postures to generate all the different sounds that we know the human voice can. So this is just a slide to just remind us that the function is and the movements are more complex than just opening and closing, but we won't dwell on that too much for the purposes of today's talk. So now these slides are meant to demonstrate the voicing task more specifically. So we're trying to visualize the voice box within the neck. And I want to orient you to that view, which is looking from the lower parts of the trachea here, the vocal cords. And what we're showing you here is that with voicing, we essentially are closing the vocal valve, or the larynx valve, and we're actually blowing air through the closed valve, which causes vibrations of the vocal cords or vocal folds. And it's that vibration that generates sound. So in order to generate sound, we need an air source or power supply, and that's the lungs. And then we have the sound source itself, which are the vocal cords, which results in the phonation, which otherwise is known as voicing. And finally, we turn that sound into speech by modulating it further with the rest of our throat, our mouths, our teeth, and tongues to generate more complex sounds, which we define as speech. this is just another slide showing the vocal cords in a similar orientation to what I showed you previously. And you're seeing that as the air is blown through, we get this vibratory cycle that occurs, which again is the sound generator of voice. So the first person to visualize the vocal cords or vocal folds was not a physician. It was Manuel Garcia in the 1850s, and he was an opera teacher actually. And he visualized the vocal cords using nothing but a dental mirror and sunlight. And of course, this was born out of his curiosity to understand where this sound was coming from. Physicians or doctors later adapted his technique, and a whole subspecialty or specialty within medicine was born from this. Now, as you can see here, using the dental mirror alone did not provide a very detailed view of the larynx or vocal cords. And as technology advanced, specifically fiber optic technology in the 1990s, we were able to obtain more detailed views of the larynx in performing all sorts of different tasks. So as we know, since the 1990s, imaging technology and really digital capture technology has advanced significantly. And so too has our ability to capture very detailed images of the vocal cords. And these slides just demonstrate some of the techniques that we can use to obtain high definition, high fidelity images of the vocal cords in action. So these pictures obviously are far superior to what we could see with a dental mirror only a couple of decades ago. But here you see the vocal cords sitting on top of the trachea or windpipe. This is the right vocal cord, that's the left, and this is the front, and that's the back, just to orient you. So with our increased ability to visualize these structures, of course, our ability to diagnose causes of hoarseness have increased, and so has the specialty expanded significantly, even significantly so, I'd say, over the past 10 years. So this is a way we can look at the vocal cords through the mouth. As you saw earlier, we can also look with a flexible camera through the nose, very well tolerated by patients. This camera sits only as far as the back of the tongue, really where a tongue depressor would sit. So most patients are able to make all sorts of sounds and allow us to really see what's happening with the vocal cords as they are performing a variety of different gestures. And this is a really magnified view of the vocal cords. Again, the image is such that the front of the larynx is here at the bottom of the slide, and the back of the larynx is at the top of the slide, and that makes this the right and left vocal cord. And so we can apply all sorts of photography techniques and cinematography. The vibrations are occurring very rapidly, more rapidly than the human eye could capture. So this slide is demonstrating the use of high-speed cinematography, but there are also other techniques that we use on a daily basis, such as stroboscopy, to really see the undulations and the vibratory properties of the vocal cords. So what causes hoarseness? Well, anything that can insult or affect the voice box can then disrupt its functions of aspiration, protection, swallowing function, and then finally voicing. So hoarseness can be caused by a variety of disorders. This list kind of highlights some of the main categories. So we have neurologic disorders that can affect the larynx, systemic diseases such as autoimmune diseases, trauma. That could be external trauma to the neck, but also intubation or a breathing tube being placed down, or even prolonged intubation where patients may have had a stay in intensive care unit and had to remain intubated for days or even weeks in some instances. Of course, surgery to the larynx can affect voice and cause hoarseness, but also radiation therapy to the general area, even for non-larynx or vocal cord disease, can cause a stiffness or hoarseness. There are different types of growths or lesions that can occur along the vocal cords, benign and malignant. And then there are also behavioral causes of hoarseness, voice overuse or misuse. And then we also have actually just age-related changes to the larynx or vocal cords, which mostly consist of atrophy or age-related muscle loss, which can affect the competence of the valve, which we discussed earlier. This is a study highlighting the prevalence of hoarseness in the geriatric population. And in this particular study, it was noted that hoarseness was quite prevalent in patients over the age of 65 at a rate of approximately 20%. And more than 50% of those patients who had hoarseness or suffered from hoarseness, more than 50% of them reported significant impairment or reduction in their quality of life. So it's something that it is receiving more attention, that we no longer just explain to patients that it's a matter of aging. We recognize that the voice changes that occur with aging can be really impactful on patients' quality of life, and it's something that we actually will treat depending on the patient's symptoms. So how do we examine the vocal cords? I showed you some slides earlier about how we could do this, but it really requires certain technology, but also an attention to subtle details sometimes to come to the correct diagnosis. The first part of diagnosing hoarseness, though, is actually just listening, listening carefully, and this is called perceptive auditory analysis or assessment. And this is something that I found actually, given the current situation, that over telemedicine, a lot of the auditory analysis can be done virtually, whereas, of course, actual inspection of the vocal cords and the larynx has to be done in person. So I'm going to play some auditory samples of what someone might call hoarseness, but I think what you'll come to understand is that hoarseness can really describe a lot of different things. So we'll play this sample, and then we'll come to explain what this is.
I really don't have much to say, but I will talk about the weather. It's been lousy. It's improving, though. New York City summers are worse than Florida. We lived in Florida. We discovered that in the summertime, we can't bear it.
So this patient has a very breathy voice, a little bit weak, not very loud, and that actually can occur with Parkinson's disease, which generally we understand causes tremors and sometimes muscle stiffness, but it also causes, in some patients, Parkinson's hypophonia, which is a term used to describe the low intensity or low volume voice, and also this monotone type voice that plagues many patients in this population. It's often recognized by family members first, but sometimes patients eventually complain that they are not well understood and that they sometimes seem to underestimate their own speech volume. The good news is, with recognition and diagnosis of this sort of hoarseness, there actually is a form of non-invasive therapy or voice therapy called LSVT, or Lee Silverman voice therapy, which is very effective at improving the loudness of these patients' voices, which really improves their quality of life, but also their family members' quality of life as well. So we'll listen to another sample of hoarseness here. This is a different patient.
I work at the Federal Reserve Bank of New York. I work in the Goldfields. I've worked there for 28 years. I hope to retire in 2 years because I'm tired of working. One thing I've realized working in the Federal Reserve, you meet the most interesting people.
So clearly that patient has a very breathy voice, even weaker than the previous one. Very difficult to even hear. And in this case, that was a patient who was suffering from vocal fold or vocal cord paralysis. Paralysis means muscle weakness. And in the case of the larynx, it implies dysfunction or a problem with the nerve that supplies the vocal cord itself, which is called the vagus nerve or the recurrent laryngeal nerve. And as you heard in that sample, patients with vocal paralysis often have a very breathy vocal character. They also will often have problems swallowing or may complain of having a weak cough, and also may feel a sensation of shortness of breath. And that often occurs more specifically while they're speaking. So we call that vocal fatigue. In terms of paralysis, what that really means is that the electrical conduction through the nerve is actually impaired. And that can occur for a variety of reasons, but essentially our brains send a signal through a nerve towards the muscle to cause it to contract. And there's some disruption in that conduction, which leads to paralysis. Now, the nerves for the vocal cords, the vagus or recurrent laryngeal nerves, are actually prone to injury because they're very long and circuitous. And that leads it to have more areas upon which it can be impacted negatively. And this is an anatomic drawing or illustration showing, this is on the right side of the screen is the left vagus nerve, and then the recurrent laryngeal nerve, which loops under the aortic arch. So it starts all the way up in the brainstem, and it descends in the neck and loops all the way down into the chest before making its way up towards the larynx or voice box, which you recognize here from our previous illustrations. So the list here is actually somewhat exhaustive, but when a patient presents with vocal paralysis, VFP stands for vocal fold paralysis, it's important to investigate the cause. And this paralysis can be caused by a malignancy or a tumor that can be pressing on the nerve. It can sometimes be due to surgical trauma. So any surgery that occurs along that course that you saw earlier can cause an injury to the nerve and an impairment in the conduction. Some cases are idiopathic, where we simply are not able to identify a cause, although we can still treat the paralysis. Intubation with a breathing tube, neurologic disease, among other causes. This is a long list of the types of surgeries that are basically operate in the region where the nerve is at risk. So we certainly make sure to take a complete past surgical history from patients to determine if the vocal paralysis could be the result of a surgery. This illustration depicts the course of the recurrent laryngeal nerve, or the branch of the vagus nerve here, right under the thyroid gland here. So actually during thyroidectomy, this nerve is routinely identified and protected, but vocal fold paralysis is a potential risk of thyroidectomy surgery. Vocal paralysis can also occur after a stroke. There are strokes that can affect the vagus nerve along with several others or other cranial nerves at the same time. So it's important to discuss with patients whether they have other symptoms in addition to the hoarseness, such as dizziness, numbness of the face. But of course, at that point, I would think that it's very important to involve one of my neurology colleagues in the workup. So we're on to the next sample of a patient with hoarseness. So I'm going to play this audio and we'll listen very carefully to hear what we think. So this is a patient that complains of having an unsteady voice, and she's told by others that she sounds nervous. And as you listen to that sample, it sounds as though the way someone might sound if they're applying a vibrato to their voice. But this is involuntary, and in this case, this is an example of vocal tremor. And we know and see tremors that people have in their hands or extremities, and or in their legs sometimes, and we can easily see that. But sometimes it's less obvious to people that sound of the voice represents a involuntary motion of the muscles around the voice box that can cause this vocal instability. So vocal tremor is defined as a rhythmic oscillatory motion of the larynx. It typically occurs at a rate or frequency of 4 to 10 hertz, which means 4 to 10 cycles a second. And the onset of symptoms typically occurs after the age of 70. And while like I mentioned earlier, we know that ET, or essential tremor, which can sometimes be familial, tends to affect the extremities, the arms or legs. It can involve the voice box or larynx in up to 30% of the cases. And there are treatments for this. So a neurologist may prescribe oral medications But when that doesn't work, sometimes patients will be referred to me to consider Botox injections to help relax or weaken the muscles that are causing the tremor in the first place. So we're on to another sample of hoarseness, and we'll play the audio.
The rainbow passage. When the sunlight strikes, raindrops in the air. They act as a prime and form a rainbow. The rainbow is a division of white light into many beautiful colors.
So that sample is called the rainbow passage. It's a standardized passage that we have patients read during voice assessments. And as you heard, that patient sounded very strained. Some might say strangled. And it was completely involuntary. The patient doesn't feel any pain. And, she goes about her day wanting to express herself, but, is told by others that she's perceived as being nervous all of the time and being asked often whether she's suffering from a cold, which she isn't. And in fact, that voice is characteristic for something we call spasmodic dysphonia, which essentially is an involuntary spasm of the voice that occurs with speaking tasks only. The onset is typically in the 4th decade of life, and there are a variety of different forms of this diagnosis. Adductor type is what you heard in that sample, where it sounds very squeezed, strained, and tight, but there's also a less common abductor type of spasmodic dysphonia, where people sound very breathy, and they often are told that they sound as though they're about to cry. So this this diagnosis of spasmodic dysphonia, more broadly termed laryngeal dystonia, is, as I mentioned, an action-induced or task-specific sustained contraction of the muscles in the voice box. When I say task-specific, I mean it doesn't occur across other tasks beyond speaking. So patients often describe having a more normal-sounding voice when singing or with emotional gestures such as laughing or even crying. The treatment for spasmodic dysphonia, the gold standard for over 30 years, is actually Botox injections. And this is a photograph from the New York Times depicting the uses of Botox throughout the body for a variety of disorders. And this is a procedure done in the office that takes less than a couple of minutes, not uncomfortable. We use an EMG machine to help guide the placement of the Botox directly into the vocal muscles. And this is a diagram depicting the presence or the location of the vocal muscle or the target right inside of the voice box, which again, we reviewed the diagrams earlier. Finally, we're arriving at one of the more common causes of hoarseness, phonotrauma. Phono means sound, and trauma, of course, is understood. So it's actually the trauma of voicing itself. So I trust that it's apparent that, just like with many other functions or activities, there is the possibility for overuse and misuse. That means if we were out late one night and used our voice more than usual, it wouldn't surprise many of us if we were hoarse the next day. But what's less apparent, I think, to many is that the vocal cords or the vocal folds during the phonation really results in high-speed collisions. The reason it's less obvious is because it's hidden or obscured from sight without the advantage of having some of the technologies to visualize the vocal cords. So those high-speed collisions of the vocal cords slamming into each other result in trauma. And of course, there's repetitive trauma, and one can imagine with certain occupations or in certain circumstances, there are people who have to use their voices quite intensively for prolonged periods of time. And what happens is, with chronic phonotrauma or chronic high-speed collisions of the vocal cords can actually lose some of their pliability or their viscoelastic properties, making them stiff. And stiff vocal cords don't vibrate very well and can result in a very rough sounding voice. Additionally, people can develop muscle tension from this. So because the vocal cords become stiff, they might use alternative posturing or might recruit additional neck muscles to help try to close the valve tighter to produce more voice. And this in turn can cause discomfort with speaking and sometimes can actually be the source of the hoarseness itself. So with other repetitive activities, we know that there are certain ways to prevent those injuries. We know that with lifting heavy objects, there's a right way and a wrong way. And these concepts exist for healthy, safe voicing as well. What I find oftentimes is that people enter this cycle where they have certain vocal obligations. They don't quite understand why they're stuck in this rut of hoarseness. And our job at a voice center is to really help the patients find their way out of that vicious cycle. And this requires a careful history, physical exam, an exam of the larynx and vocal cords, and then an accurate diagnosis and treatment plan. So you saw this image earlier, which is depicting the vocal cord vibrations, but I want to explain it a little bit more in terms of the collisions that are occurring. So this is the view where the windpipe or trachea is down here. These are the vocal cords from a front to back sort of view, and this is upwards. So we know that air is being blown through the vocal cords when they're in the closed position. And through a physics or physical property known as Bernoulli's principle, this high velocity airflow through a narrowed space creates a negative pressure, which essentially sucks the vocal cords together, which initiates this glottal or vocal vibratory cycle. Now, what this image doesn't really depict is that the vocal cords are actually vibrating at a frequency much faster than what you see in that image, and actually much faster than the human eye can capture. So this slide is just meant to demonstrate the concept of frequency as measured in hertz. Hertz means how many cycles per second. So as you get increased sinusoidal waves in a matter of a second, it reaches 5 hertz or 5 cycles per second. Well, the vocal cords are vibrating much faster than that. So when you look at average frequencies of voice for male and female, the average male frequency is about 120 hertz. That means 120 cycles per second. I mean, think about that as I'm speaking with you. 120 cycles per second. Think about all of the collisions that are occurring. And if you thought that was rapid, think about the female voice, which of course is higher in pitch, and therefore the vibrations are occurring at a faster frequency. The average female voice is above 200 cycles per second. That's really, really fast. And that is a lot of collisions occurring. So this slide is not, these are not vocal cords, these are actually, this is an image of a star collision or stars colliding, but it's just to convey the point of the traumatic forces of collision. So finally, I'm going to show you a video of a patient who is a teacher, who's been experiencing hoarseness, which has been getting worse over the course of the school year, and even gets worse towards the end of the day. This is an exam called the stroboscopy laryngoscopy.
Good.
So this is the back of
Just
the
in your
tongue
normal
here.
voice.
This is the uvula that you just saw.
Even though I'm holding your
And
tongue,
we're
really
trying to look down here where the vocal cords lie.
Good.
Right and left.
Go.
You see down into the
Now
airway or
from low to
windpipe
high,
here.
go. All the way up. Low to high. Now from, good. Now from high to low.
So what you might notice is that the edge of the vocal
Clear your
cords are
throat.
not completely straight. There's some swelling at the midpoint of the vocal
Again,
cords,
gentle breath and then hold
and
soft
that's what's
E as
causing
long
her
as
hoarseness. These swellings actually don't allow the valve or the vocal cords to close
Go.
completely, and they're also
All
a
right,
bit
all done.
stiff.
You just
So the diagnosis there is vocal nodules or vocal fold nodules, which are benign. And they're also known as singer's nodules, but they don't only occur in singers. Vocal nodules are a result of voice overuse or misuse, and it's a result of these really, really fast collisions occurring at this area of the vocal cord called the striking zone, which is the midpoint of the vocal cords. That's simply the part of the vocal cord that see most of the traumatic forces. And vocal nodules themselves are really just calluses or a firmness or stiffening that occurs. And the good news is that vocal nodules don't require surgery for treatment. They respond very well to non-invasive therapy in the form of voice therapy, which means essentially working together with a speech language pathologist or voice therapist who usually over a matter of weeks can either resolve the nodules themselves or help restore pliability for more normal voicing. So there are a variety of other types of diseases or lesions of the vocal cords that can occur as a result of trauma to the vocal cords or phonotrauma, not just nodules, but I think that was the most typical example, and so we'll leave that there. But in terms of vocal health, which is the topic of today's talk, how do we prevent vocal injury or phonotrauma in the first place? There are, as I mentioned, many other types of activities which I think are more understood or recognized to involve repetitive actions, repetitive traumatic forces, which can cause injury. So we know that in those occupations or in those contexts, we know about certain safety rules, certain devices that can help promote safety or prevent injury. And especially in athletics, we understand that in order not to cause injury to those ligamentous, muscular, and cartilaginous structures, stretching and warm-ups are important. So the same principles exist for safe voice use. And as some of you can imagine, there are certainly those who use their voices on a level that could be considered athletic, and that would involve people who use their voices occupationally, whether that be a professional singer or a teacher. And of course, we know that after an injury, physical therapy can be very important in strengthening muscles and encouraging more healthy use of muscle groups. And this is really akin to what speech language pathology or voice therapy is for. So more specifically, how do we promote vocal health? So the first thing I share with patients is sometimes the need to budget our voice use. Because it's in an obscured area or hidden within the neck, I think some of us may not realize that we might have a finite amount of voicing that we should be engaging with in a particular day. This might mean that if someone has a significant speaking obligation coming up, it would be important to rest their voice before and rest their voice afterwards to prevent injury. I also discuss the topic of confidential voice use with my patients. Confidential voice use means speaking in a voice or on a level such that you just need the person right next to you to be hearing you. You shouldn't have to speak to people necessarily across the room, which causes you to overuse your voice and sometimes misuse your voice. So this might involve making sure that when you speak with colleagues or family, not to have to shout across the room or shout across the house, but to try to make sure that people are at arm's length with you. There's also the concept of minimizing background noise or competing background noise. So that might involve, if there is background music or other noises that you're having to compete with, you end up also obviously overusing your voice and sometimes misusing your voice, which can cause injury as well. In some settings, amplification through the form of a microphone can help prevent us from overusing or misusing our voices. And I find this is particularly applicable to some of our teachers, lecturers, and performers in some instances. Now, room acoustics is also something to consider. And I wrote here, think restaurants, because that's one of the most common situations where patients will present to me after having been out at a restaurant with friends and having to, yes, also compete with background noise. But certain restaurants are known, and it's been described in the newspapers actually, where they have poor acoustics so that you've had to really speak so loudly to be heard. And so patients often struggle in these environments and often develop hoarseness sometimes thereafter. Another way to promote vocal health is to use headsets when possible. And I think this might be especially applicable in the world of virtual meetings. So having a headset allows us to not have to speak so loudly to be heard, and also avoiding the use of a speakerphone, which also leads people to have to speak more loudly, overuse or misuse their voices as well. For some individuals, especially performers, a vocal warm-up can be very important. And also there's the concept of technique modification. So we can develop bad habits, not just in terms of voicing, but in terms of our health in general. And so sometimes working with a voice therapist or sometimes a vocal coach or voice teacher can help people use the muscle groups appropriately to prevent misuse. Something as simple as hydration, drinking enough water is very important to help make sure that this organ, the larynx, the voice box, is well lubricated to help reduce frictional forces. And finally, there's something that's a bit more specific in terms of exercises that in the field we call semi-occluded vocal tract exercises. An example of this is straw phonation. So what is straw phonation? So straw phonation is sort of what it sounds like. It's pursing the lips around a straw and producing voice or sounds, generally in the form of a pitch glide, which means from going low to high. And essentially what this does, it produces a back pressure that helps relax the muscles above the vocal cords, which promotes healthier voicing. But that back pressure even reflects at the lips of the vocal cords themselves, helps them vibrate more effectively, reducing unnecessary trauma, and also has been shown to improve the pliability or the vibratory properties of the vocal cords. So this is something that I often recommend to patients, although nowadays we often consider the waste of using all of these straws. So we do provide reusable metal straws, which are now widely available for purchase if people have those considerations. And this is just a handout that we sometimes give patients about how to stay in vocal shape, and it covers much of what we talked about already. But there are also some additional considerations on here. Specifically, certain medications might cause hoarseness or drawing. Acid reflux, I think, gets a bad rap and is probably overdiagnosed, but certainly acid reflux can aggravate voice disorders. And then finally, get scoped. And what this means is, while we, I think, appreciated today during this webinar that we can learn a lot from the sound of one's voice, but national guidelines suggest that if someone is experiencing a change in their voice that lasts for more than 2 to 3 weeks, it's ideal and recommended actually that the vocal cords themselves are inspected to help make a diagnosis. So that really concludes the talk today. Of course, as I mentioned earlier, this is a pre-recorded webinar, so I can't unfortunately take live questions, but I'd be happy to field any questions via email if you have any. If you have an interest in learning more about our voice center, also feel free to reach out. This is our office phone number and the website for EL Medicine. It's been my pleasure speaking with you today, and I wish you all happy and healthy voicing. Bye-bye.